Good morning, everyone. Can you hear me okay? Loud and clear. Welcome to the last morning, which feels like it should be a Friday, but it's the first of the week. We all have to go back and work the rest of the week, which is good. Hey, welcome to the fastest 1-hour presentation on health policy you probably will have this entire year long. I'm going to speak only 15 minutes on what's happening in telehealth at a national level. Nate then is going to do the heavy lifting and fighting with alligators, actually talking about what's really happening at the state level. And then our intention is to give about half an hour for Q&A, because in the past, that's really been the best part of these sessions. I'm thrilled to be back here again. Alan Morgan, CEO of the National Rural Health Association. We're a nonprofit membership organization that represents more than 90% of the nation's rural hospitals, rural health clinics, and rural community health centers. Focusing in on policy, advocacy, research, and networking. So let's take a look at what's happening at a national level, in specific with rural America. So hopefully you're able to relate how that impacts the community that I'm interested in. Number one, if you've been following the news, you've been following the big news about rural hospital closures nationwide, which also has hit some of the states that are here, most notably Virginia, in particular on that. Nationwide, since 2010, 103 rural hospitals have closed. You've all heard that. There's two other aspects of that which I think are important that aren't getting enough news. So this is where you actually get new information. 103 rural hospitals closed is not actually accurate. There's actually been 112 rural hospitals closed. See, what happens is, if you close and you reopen, we don't count you as closed. So what I'm telling you is once your hospital closes, chances are good you've lost your rural hospital for good. Less than 10% of the nation's rural hospitals have reopened after their closing. The relevant point of this is data from the National Rural Health Association indicates that 1/3 of the nation's rural hospitals are at financial risk for closure now. That's roughly 700 rural hospitals at risk for closure. Now, the relevance for telehealth in this actually is twofold. Number one, the potential for new service lines. Again and again, I've heard of struggling rural hospitals that have created a telepharmacy program or other access to specialty care programs using telehealth and have opened up a new service line to help keep their doors open, number one. Number two, teleconsultation, the ability to recruit clinicians to your community, knowing that they're not going to be out there practicing alone, that they have someone there that they can talk with and bounce off ideas. So very important, is actually proven to help in physician recruitment and retention. Again, so very key in keeping these rural hospitals open. For those of you that attended our Policy Institute a couple months ago, you also heard a disturbing new data point that hadn't been tracked or highlighted before, and that is the closure of the nation's rural health clinics. More than 300 rural health clinics have closed in the last few years, something that's been underreported. Again, this is a lack and a loss of primary care in our nation's rural communities. One thing that has been reported but not highlighted enough, has been the rural pharmacy closure issue. Now, 1,230 rural pharmacies have closed since 2003. Hasn't made the national news as much, but obviously everyone here knows the importance role that rural telepharmacy can play in addressing this issue. And I expect this to continue because only a month ago, Walmart announced the closure of more than 200 of their stores across the country. Right now, we're looking at data. What does this mean for rural? Think about that for a second. Many times people say, well, it's okay, not worried about the pharmacy in our community. We've got Walmart, especially in a rural context. What does this mean for the future from a strategic direction for Walmart? What does it mean for rural America too? So I think this emphasizes the need, role, and responsibility of rural pharmacy, rural telepharmacies going ahead. Behavioral health. Behavioral health. You've had sessions on that already. Nationally, I enjoy seeing the data on telebehavioral health. One of the key components is the impact and actual benefit of having telebehavioral health out there. I get a sense and a sensation that nationally this is expanding fairly rapidly, but we just don't have the data on it to really know on this. Huge potential going ahead. Rural veterans, rural veterans. Everyone knows that the VA is a leader in telehealth, right? Okay, so surely everyone in this audience knows the role and responsibility that the Veterans Administration plays in serving our rural veterans. 3 days ago, I had the opportunity to speak with Kaiser Health News Daily reporter talking about the VA. I said, who cares for our nation's rural veterans? The VA, right? Everyone knows that. There's roughly 5 million rural veterans out there. Well, unfortunately, if your health need is not service-related, you cannot obtain care through the VA. So that cuts off a large component of our nation's rural veterans. If you can't access a CBOC or a VA facility because it's too far away, that cuts off another chunk of our nation's rural veterans. And that's not even getting to the veterans who just do not know that they're eligible for VA services, which cuts off another chunk of our veterans. What I'm telling you is the numbers from the Veterans Administration indicates that of the 5 million rural veterans, half do not seek care in a VA facility, do not seek care in the veterans system. That means that half of the nation's veterans are getting health care outside of the facility. This is so very important because last week the VA released the updated modernization plan, and if you caught the news last week as well, the Secretary of the VA is asking for $1 billion to be directed towards telehealth applications. So what does that mean for each of you and the veterans in your communities? What it means is the VA recognizes they've got to find a new way of meeting the needs of the rural veterans. They've got to use it through telehealth. They've got to be able to partner with local providers. So how do they use their capacity and expand telehealth into a rural context? I think this is something, looking ahead, we're going to be hearing much more about, because simply stated, the VA does not have capacity right now to serve additional VA rural veterans. They just don't. You know that from seeing the national news on that. I think from a policy perspective and from a community perspective, we have to figure out what is the best way to partner with the VA to enhance those services. And the important role is that VA telehealth system that's already established, how can we utilize that to improve access to care for our nation? Seniors care is something you're going to be hearing a lot more about coming up in the next 2 to 3 years. We're kicking off our annual conference in May with a focus on the issue of rural senior loneliness and isolation. A great opportunity for telehealth going ahead. Last year there was a first research look at rural senior loneliness and isolation. And if you love data, this is a great data to look at because it tells a good story about rural seniors. As you know, rural America has so many things that are lacking. The one thing we have is a sense of community, the collaboration, the networking, the family system of support that we have in a rural context. So not surprisingly, the data actually showed that there are a lower percentage of the nation's seniors reporting loneliness and isolation. But those that are reporting really have severe cases of loneliness and isolation. So even though it's not as high as urbans, the ones that are experiencing problems have significant problems, which makes sense because in a rural context, you don't have the infrastructure to deal with this that you would have in an urban area. So going forward, to deal with this, we have to figure out how do we utilize telehealth to reach these seniors in their homes in a homebound application going ahead. Opioids, opioids, opioids. Obviously, right now we're in the process of both USDA, HRSA, Office of Rural Health Policy grants that are being implemented across the United States for innovative approaches towards opioid treatment processes. There is a substantial lack of evidence-based successful models in a rural context to deal with this. Part of the issue and challenge, obviously, is access to behavioral health specialists. And it's going to be interesting over the next 1 year, a focus looking at how is telehealth implementing successfully to deal with group consultations and other behavioral health needs. So over the next year, you're going to be hearing quite a bit about that at a national level. All of this, however, needs access to accurate data. One of the challenges I think that we all face, and one of the things that the National Rural Health Association has been advocating, is good national data about implementation of telehealth solutions in a rural context. Now, if you think about it, you think, what are you talking about? Last year, HIMSS had a national look at telehealth implementation. The Rural Policy Research Institute had a national look at telehealth implementation. Both of those national studies released last year relied on data from 2013 and 2014. This is 2019. And you're going to hear from Nate, many of the regulatory and legislative changes that have happened in the last 3 years. So we're not capturing the changing face of telehealth across the United States. We need accurate data. On that same issue, a year and a half ago, there was much anticipation and hoopla on the FCC broadband map. Okay, I heard the size out there, so I don't have to go into detail about that, but I will. You can't know how to change policy and where you need broadband unless you have an accurate map on it. And if you followed it, the discussion over the last year and a half, from great excitement to questioning to concern to outrage. Last year I was in North Carolina where the group turned on the FCC commissioner saying this data is not even remotely accurate. We can't know what we're facing with this until we deal with it. One of the challenges I have, and I know that it's the case in a lot of the communities out here, is I'm even hesitant. In a group like this, I'll talk about broadband. I'm hesitant to go out into the rural communities and start talking about broadband because it makes people angry. The clinicians say, I don't even have cell phone service. Who cares about broadband? It's just an angry topic to talk about. Nationally, I get a sense, without data, that most rural hospitals have broadband access, not all. But it really is the clinical component. In a rural context, the clinicians who aren't able to access the medical records from home, and then when they get to the clinic, they still don't have good access. They have to get to the hospital itself to be able to look up the electronic records they need in particular. Okay, I am actually staying on topic, and let me close with this. Over the last 8 months, the U.S. Department of Health and Human Services internally has engaged in a look at regulatory challenges and barriers for rural providers. Seema Verma, the administrator of CMS, has requested time at our annual conference in May to what I hope will be a rollout of some significant regulatory proposals to impacting in a beneficiary manner rural populations. And I'm hopeful in the announcement we get some clarification from her about Medicaid and telehealth and maybe some guidance for states in implementing telehealth policy in the Medicaid context. I don't know that for sure, but that is obviously the hope and expectation that we have. So stay tuned because we're only a month away from hearing at least where the administration stands on the evolving regulatory environment for telehealth from Medicare and Medicaid. And finally, let me close on this. I hope I hope you all had the opportunity. The House Telehealth Caucus just closed their public comment on changes to telehealth legislation necessary moving ahead. This is a group of advocates within the U.S. House of Representatives looking at how do they improve the telehealth environment. And so most organizations, National Rural Health Association, ATA, other groups, and hopefully individuals as well have shared your thoughts on this. Again, I go back to beating the drum. It's really tough to know what regulatory and legislative changes in the past have substantially improved the environment without access to accurate data and research. It's not always the most popular thing to advocate for, but for us to make our strong pitch of what needs to happen, we just have to have the access to data. So that's a quick look at what's happening in rural America today, the role of telehealth in a rural context, what we're expecting in the coming 2 years from a congressional and regulatory look at it, and definitely stay tuned next month, and hopefully we hear some good announcements coming out from CMS. So at this point, I'm going to turn it over to Nate.
Thanks, Alan. Good morning, everybody. So my name is, I don't know if this will be double mic'd. Okay, good. My name is Nate Laxman. I am a partner healthcare lawyer at the law firm of Foley & Lardner. I'm the chair of our telemedicine and digital health team across the country. We have about 14 lawyers just dedicated to our industry. I think it's fair to say we do more of this work than any law firm in the country, probably the world. I'm really proud of our team, what we built. I see a lot of familiar faces in companies that we are fortunate enough to work with in the audience today. Here's the first slide. I'm on Twitter, so it's a telehealth. It's all just telehealth virtual care. You're free to take shots, post it, follow us, whatnot. If you do, tag it with hashtag Matrix 2019, so Kathy and her team can get some exposure to that. And with that in mind, this is the 8th annual Matrix conference. The first one had fewer than 200 people. Now we have almost 500, right? So let's just give a big round of applause to Kathy, Karen, and the rest of the team. It's stellar. My children are waving at me in the back corner there. Future generation of telehealth consumers, you can say. That congressional RFI, right? It was almost an April Fool's prank because Congress really did not give us a lot of time to respond, about 2 weeks. That said, I helped contribute to the ATA's comments. Those should be published within sometime this week. And I would encourage any of you who have comments from an association or your particular organization, they're technically public documents because you sent them to Congress, right? Put them online somewhere, share them so we can see each other's ideas, right? Just because someone is an elected official does not make them an expert, right, on anything other than maybe getting elected, right? And so they need our feedback, our ideas, right? And when I say our, I mean your ideas, okay? And if you have some good ideas here, share them with the other side of the audience. It will make our industry better. So I would really strongly encourage you to do that. Okay. Today I'm going to go over licensure, practice standards, prescribing, and payment for the 9 matrix states. You might have seen me give other presentations in the past. I talk about a lot of legal and business issues, try to give you solutions. This is a little different because it's just going to be pictures, okay? A bunch of pictures and heat maps. If you have interest in, for example, entrepreneurs or direct-to-consumer, I'm doing a presentation on that at the ATA's annual meeting in a couple weeks, so you can check it out there, okay? Telemedicine and licensure. Interstate licensing compact. So here's a heat map of the current state of the 9 matrix states, right? Maryland just joined the interstate licensure compact. Kentucky is pending. And you can see 4 states are in, 4 states are out. Again, 1 is pending. Has interstate licensing compact been phenomenal? It's okay. It certainly never manifested to the promise that we had hoped it was when it's in its draft formulations. But it has been a vehicle. And I can say a number of the companies that we work with, they do use it as, if nothing else, as a single clearinghouse to help expedite the paperwork of the applications. Compare that to the nurse licensure compact. So here's the matrix footprint. 5 states in, 3 states out, 1 state pending. Dr. Hollander, please, you're going to have to get on top of Pennsylvania. We're waiting for you, sir. The nurse licensure compact is way better. It predated the physician one, and what that is, it's a true seamless reciprocity. So let's say you're a nurse and you're licensed and you work in the state of North Carolina. You can do nursing services, telemedicine or otherwise, in all of those dark blue states. Okay? But if you went to move to South Carolina, even though you're licensed in North Carolina, if you're living and working in South Carolina, then your reciprocity is not live, because South Carolina is not a participating state. And you're seeing a number of other types of professional licensure types use compacts as well, because it's really the only way that they're able to have something close to a national or unified licensure, right? The 10th Amendment states rights. We cannot have Congress force upon the states national licensure for these state-reserved professions. And so what they do is say, let's all agree on a homogeneous, identical suite of statutory language. And here it is for physical therapy. So this was just introduced, I think, a couple of years. Do we have any PTs in the audience?
There's actually 22 in the U.S.
22 physical therapists in the United States. I'm just kidding. Yes, I'm joking. Yeah, it's fantastic. And I really would give a lot of credit to the PTs and the Physical Therapists Association with how quickly they mobilized and got these states on board. So if you're in a professional licensure that is not a doctor, is not a nurse, you can do it too. And I would encourage you to look to the PTs and how effective they've been. Now, is there any type of concept of a federal law that would supersede state licensure with regard to healthcare? Who watches, like, sports? Nobody? Okay. All right. Well, maybe it's not a very sports-oriented crowd. But yes, the president signed into law last year the Sports Medicine Licensure Act. Who has heard about this? Okay. Well, the physical therapist is a very well-informed person here. Yeah. So look, what they said is, if you practice sports medicine, if you're delivering services to an athlete or staff on the team, and you're licensed in one state, you need not get licensed in any other state, okay? You can travel with the team, you can do it via telemedicine, whatever. The only exceptions to that are you have to have a contract, right, with the team or the sporting association or the school, let's say the university. You can't deliver services in a facility, right? So you can't, like, supersede the local hospitals, and you can't do it during emergency transport. Why? Because the ambulances and the hospitals don't want you to gobble up their business, okay? Other than that, it supersedes state laws or provides an exception. Why do we have that, where we don't have it for everything else? Because sports are cool, right? Basically, right? The sports medicine, the physical therapists, the athletic trainers associations were very effective in mobilizing and lobbying Congress for that. It was tucked into part of a larger piece of legislation. Okay, on the topic of licensure, here's an exception most commonly utilized in telemedicine arrangements, particularly interstate, is the peer-to-peer consultation exception. It's intended for doctors to kind of talk to each other, make medicine better. Hey, I'm out of my depth, please help me out here. Now, what we're seeing this used more heavily is online second opinions, right? A direct-to-consumer service, but it's built around a peer-to-peer consultation exception where the patient has a local treating physician who's requesting this specialty consult, or e-consult services. Who offers, or is involved in e-consult services between, provider to provider? Okay, a few of you. You're going to see more of this in the next couple of years. I guarantee it. You will see more of it, right? And the two options are, one, have the specialist license in all the various states, which is possible, but it can be cumbersome. Or two, follow the peer-to-peer consultation exception to licensure, thereby allowing that subspecialist to export her expertise across the country to other providers, making medicine better, making that subspecialist, let's say someone's located in Colonial Williamsburg, Virginia, and they're like a pediatric oncological dermatologist, right? Hopefully, there aren't enough of those cases in Colonial Williamsburg to keep that person busy full-time. So what can she do? She can have contracts with hospitals or provider groups in a whole bunch of different states and export her depth of expertise, and those patients can enjoy it. You can do this in about 40 states if you're charging for it. So what I put up here is It's really designed to show you, like, don't be too fast and loose with this, right? Just because there is a peer-to-peer consultation exception to licensure does not mean that it applies universally or in every particular scenario or situation, okay? And every state has one, with the exception of Maine. Last year, Maine created a telemedicine consultation registration that eliminated their peer-to-peer consultation exception. Okay, so it's like $500. It's not a license, but you do need to register with the Board of Medicine to get that. All right, switching from licensure to practice standards. We talk about modalities, okay, before I confuse you with this picture. Does anyone know the basic modalities of telemedicine? Audio, video. What else? Store and forward. Someone said text. What about the interactive audio with store and forward? You know, kind of call it the teledoc model, right? So those are the three main ones. Interactive audio video, interactive audio with store and forward, pure store and forward. Interactive audio store and forward, what is it? It's basically completing a questionnaire that pre-populates a SOAP note, the doctor looks at it, then they do a phone call, okay? You contrast that with audio only. Right? Pure phone. So I pick up the call, pick up the phone, talk to Dr. McMenamin. He has no idea who I am. I'm like, hey, Dr. McMenamin, I'm feeling this kind of way. I want you to diagnose and prescribe me. If he were to do that, it would not be compliant pretty much with all 50 state expectations for minimum modalities. Similarly, text only. You know, that's not allowed. Email, they even use US mail if anybody's plans to practice medicine via US mail. I would discourage it. Okay, so here you go for the 9 matrix states, the minimum required modality to create a doctor-patient relationship, okay? I'm a lawyer, I chair our national team, we do these research projects across all 50 states, but for our present purposes, I'm not giving you any legal advice, there's no client-attorney relationship created, so please just use this as an informal way to educate yourself about it, but I do stand behind these findings. Okay. Audio, video, interactive audio, store and forward. Of your 9 states, only one, Delaware, mandates the use of interactive audio video to create a valid doctor-patient relationship. You can see West Virginia, New Jersey, and Maryland, they allow interactive audio with store and forward, but they do not allow pure asynchronous. Kentucky does. You could thank Rob Sprang and the rest of the folks in Kentucky for some of that. And then you're wondering, well, what are these dark gray states? Pennsylvania, Virginia, North Carolina, it says silent. What does that mean? Okay? It can mean one of 2 different things. The first thing is that there is no law on it. They don't have a definition of telemedicine in their practice standards or medical board rules, and that is the Pennsylvania example. Okay? The second is Virginia and North Carolina, where they have a definition for telemedicine. They have practice standards and requirements. But they have deliberately elected to define telemedicine broadly in a manner that allows for some oversight, right, of quality and services, but flexibility for innovation and changes in technology without having to revisit these rules. So for example, states like this would define telemedicine as the delivery of medical services between a doctor licensed in this state and a patient at another location through the use of secure electronic communications. So telemedicine is, that, secure electronic. They don't say interactive audio, video, interactive audio, store and forward, async. They define it broadly, okay? And that's by design, so you can embrace that. But let's see, this is to create one. So this is your brand new patient relationship. And now let's see, what do these states set forth when, after a doctor-patient relationship has been created, okay? Here's the before, here's the after. So take West Virginia, for example. You have to use interactive audio, store and forward as the minimum modality, but after you've created it, they explicitly say you can use store and forward, okay? So what does that mean? Let's say you're a hospital in West Virginia, right? You have a patient. You want to be a telehealth, pure telehealth? Okay, so you use interactive audio or you use audio video for the first time, but after they've been established, you can use e-consults and store and forward for your follow-ups, right? Same thing if you're a direct-to-consumer entrepreneur company, but what you can't do is West Virginia use store and forward for the initial doctor-patient relationship created, okay? Patient-informed consent requirements. Of the matrix states, 7 require patient to give informed consent to telehealth services, 2 don't. Why did we make these red? You don't have to give informed consent when you walk into a doctor's office, just for like your normal E&M, oh, I'm feeling ill, I want to have a checkup, right? They don't say, okay, here's a consent form. You have to for telehealth in about half the states. I think some of it's kind of silly. I think it could be well-intended. Some people say, this represents just another barrier, an artificial restriction that boards have put in that can kind of inhibit the use and deployment of telehealth. Well, I agree with all of that. In fact, some boards in some states that formerly had informed consent requirements for telehealth only have rolled them back and eliminated them. It should be pretty obvious to the patient that the doctor isn't physically in person with them when they're doing the consult. I don't know, though. There's also challenges, too. Let's say it's a telestroke scenario, right? Do you think the patient's actually able to give informed consent to anything? Certainly, if you're a hospital administrator and you're like, please sign here, sir, before you get admitted, they may make that position. I really think, though, that this isn't that much of a barrier, right? Build out in your platform, your front end facing the patients, a click sign capability for the informed consent form, right? A little box, have it unchecked in the beginning, please. Don't pre-check these boxes. And say, I agree to the telehealth informed consent form. Informed consent form, that could be a hyperlinked document that they click, it pops open. If they don't want to read it, they don't have to, but then they're click signing. There's something known as the Federal e-Sign Act that is absolutely allowed. There is your solution. Telemedicine patient identification verification, ID verification requirements. So all of these states except for DC, Pennsylvania have an explicit requirement. The doctor needs to verify the identity of the patient in connection with the telemedicine service. How do you do that? Give me your name, address, right? Something to match up when they created their user account or completed their questionnaire matches the medical record. It's very easy to do if you're doing audio video, a little less for interactive audio, much more challenging for store and forward if it's a pure async play. So what do some companies do? They require the person to take a selfie and then a picture of their driver's license when they're creating their user account for the first time, and then they just store that information. Okay, so there are solutions available for you to do that. Telemedicine special notice or disclosure requirements. So this could be certain language that you have to warn the patient about or caveats or whatnot. They exist in every state except for Pennsylvania right now among the matrix states. One of the more notable ones that I could give an example of is Texas. Okay, so in Texas, if you're going to deliver services via telemedicine, whether you have an in-person clinic or not, you have to tell the patient how to file a complaint with the Texas Board of Medicine, right? And it has to be in English and Espanol. And so they have very specific language. It's actually in the regulation. You could put that as part of your informed consent form, or you could put it at the bottom of your app or website, where you have terms of use, privacy policy, disclosures like that. Recording telemedicine consults. So this was from our 2017 survey. I talked about this a little bit last year, the survey in general. I was really surprised that 43% of the respondents, which are hospitals and traditional medical groups who use telemedicine, not pure telemedicine companies, said that they do record their telemedicine consults. In order to do so, really you need to be aware of state law on permission to record phone calls. They call it one-party or two-party consent states. The red ones, you have to have both people's permission. One party, you just have to have one, which is very strange. I find that very strange because that's okay, I'm going to record this call, and I give myself permission to record it. Okay? Vermont is the only state that actually straight up just prohibits recording telemedicine consults, period. If you do record these consults, though, they are medical records, so then keep that in mind. You need to store them. Telemedicine and prescribing. Here's states with internet prescribing rules. All of them have it except for DC. So this is an example where Pennsylvania does have a law or a rule on this issue that says, what is the difference, though, between internet prescribing and asynchronous telemedicine? Does anyone know? Emily Wine, you need to know the answer to this, I'm sure. Yeah, thank you. Okay, so the main difference is this. Internet prescribing rules, they were created in the late 90s, early 2000s in response to these online pharmacies where you could buy Vicodin or whatever, right, without any legitimate medical examination. You put basically your name, address, what you want, your credit card number, hit submit. Right? Some doctor, in some seedy hotel room, smoking a bunch of cigarettes, is just hitting yes, 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 yes all day long. Okay? And it's all funded by the pharmacy. That's basically what was going on, and people were getting hurt. Okay? So the DEA took the point to kind of define this, and all the states sort of copy-pasted. And these internet prescribing rules essentially say You cannot diagnose or issue prescriptions based solely on responses to an online questionnaire, okay? Based solely on responses to an online questionnaire. Does this mean that you cannot use online questionnaires as part of your process? No. Of course you can. In fact, it's a good idea. It can help speed things up, both for the patient as a consumer and then the providers for the intake and question-making process. These exist in 41 states. So 9 states don't have a prohibition on it, okay? So when you're doing this, you need to read this as an overlay of telemedicine rules. Pennsylvania, for example, they don't have anything that defines modalities, right? So you could do asynchronous in Pennsylvania, but you should not do internet prescribing in Pennsylvania. How do you thread that difference? The answer is by the use of clinically relevant extrinsic medical information. Okay, concrete example, you want to do a derm, you want to offer direct-to-consumer derm. They'll do a questionnaire with their history, background information, all that, and then they have to upload photos of whatever the particular lesion or marker it is on their hand, right? Then the doctor is able to take a look at their background information as well as the extrinsic medical information. Or hair loss, right? Pictures of the scalp. Or you want to use some prior medical record within the last month, or Bluetooth-enabled wireless peripherals. Hey, I don't want you to tell me what your blood pressure is. Use this cuff, right? That's going to automatically sync with our app and then will give us the data from an FDA-regulated medical device. Or at-home diagnostic testing, whether it's rapid strep or whatnot. In my opinion, this is absolutely the future, particularly for DTC telemedicine. You're going to see an explosion of this in the next 2 years, 100%. Why? Okay, I think it's even better than the audio-video, interactive audio, right? In those audio-video or interactive audio, yes, you can visualize the patient a bit, but you're primarily relying on the patient's own representations of their perception. There is no real way to validate the veracity of what the patient is telling you because you don't have any clinically valid extrinsic medical information. But you are seeing a lot of these pure async offerings that do couple at-home diagnostic testing. And I think you're going to see more of that, and I would embrace it. That's internet prescribing. What about telemedicine prescribing controlled substances, right? Who has issues with trying to figure this out? Okay, well, only a couple of you. I'm glad that everyone else has it absolutely dialed in. There's the Federal Ryan-Haight Act, as I'm sure everyone is aware of, or most of you, which basically is a federal law. It says you have to do one threshold in-person examination with the patient before you can prescribe controlled substance. Not every time, it's just one. It's not clinical in nature either. That isn't going away, but they have a special registration that they're going to make available. It should be live by the end of October. October 24 is when the deadline for DEA to promulgate those regulations. They haven't done so for 10 years. The president signed a law last October, said make it happen. Now, once that goes into effect, you still need to comply with state law, right? So here's an example. The light blue states are silent on telemedicine prescribing controlled substances. The dark blue ones say it's expressly allowed. Sometimes they have limitations, without an in-person exam, I should say. Some of them say you cannot prescribe narcotics for chronic non-malignant pain. That's an example. Other ones might say you can prescribe controlled substances via telemedicine for treatment of psychiatric disorders, okay? And if your state has a law and you're not a fan of it, you can change it. Right? We helped write the one in Connecticut that last year was signed into law by Governor Malloy, allowed telemedicine prescribing of controlled substances for treatment of psychiatric disorders, MAT-SUD. So that's great for folks in Connecticut. Delaware, prohibited. So who's from Delaware? Let's get on top of things here, right? Come on, Delaware. Telehealth insurance coverage laws. This is a topic that should be familiar to most people. Here's the heat map, okay? The blue states have coverage parity, which says that a health insurance plan is required to cover a service delivered via telehealth if that same plan is required to cover it when delivered in person, right? So I'm a member, I pay my premium every month, and they say, Nate, we're going to cover this suite of medical services. Great. If I had a coverage law in my state, which I do not, I could choose to get that service via telemedicine or in person. About 36 states have these laws. By and large, if the state doesn't have a law, health plans will tell you, or really they'll tell the lawmakers that they cover these services, but in reality they don't. And folks in Pennsylvania, I'm sure you know what I'm talking about. They made a push last year. I think they'll renew the push again. So again, kudos to Delaware in this scenario, as well as Virginia. You have coverage and payment parity language, which means that the plans essentially need to reimburse the provider at the identical rate for virtual or in-person services. Okay? Here's the 4 main hallmarks in all the work that we do for a number of years that I think leads to a successful telemedicine offering, whether it's from a hospital or whether you're an entrepreneur in a startup. First, it has to be meaningful, right? Meaningful, and that could vary. Meaningful to the patients, right? Or it could also be meaningful to the providers. We know that increasingly doctors are feeling a significant amount of burnout, overwhelmed. A lot of them are turning to virtual services as a way to deliver care on their own time in a little bit more of a relaxed environment. So it's got to be meaningful. It has to be clinically appropriate. So I'm not a doctor, right? You do not ask me what is or what is not clinically appropriate. But the standard of care for a service delivered via telemedicine or in person is identical, okay? So you're not going to be able to get out of trouble by saying, oh, it was just telemedicine, I didn't have any opportunity. No, if that happens, you're supposed to refer the person to an in-person exam or diagnostic testing, draw upon your independent medical decision-making and pump the brakes there. The third is it needs to be legally compliant. Okay? And that's not just with all these state telemedicine rules that we talked about. That is one thing. But it's also with fraud and abuse, Stark, anti-kickback. It's really easy to build a successful company and offering if you break the rules, right? Of course. Oh, we want to get a whole bunch of patient referrals. Okay, let's just pay someone like $50 for every patient they send us. Our business will go through the roof. Yes, it will. Okay? Until you're sitting in like a prison cell and saying, oh my gosh, what did I do? It's easy to do it if you break the rules. Just don't break the rules. So you can do it by offering like a legitimate service that in itself has value and should be legally compliant. Or for the entrepreneurs in the audience, you'll say something like, okay, I know we need to do legal, I know we need to do this, but we'll do it after we're a success. We're just bootstrapping it, we'll build up. Once we get some investor capital, then we'll be able to do that. Great, okay. But you've built out a model that inherently is not following the rules. Of course you're going to have ROI. Of course you're going to have this MRR. But then once you hire like your lawyer, or if you want to get some real investment capital, they'll do due diligence and they'll say, this is not legal, you have to change it. And by changing it, maybe your model doesn't work anymore. We don't want to invest. That is like super sad, okay? The last part is it needs to be scalable. What this means is either within your system or your hospital, like other departments should be able to copy paste it and do what you're doing. Other folks in the audience, just like any published clinical studies, should be able to see what you're doing and say, that's awesome, we're going to apply those same principles to our patient base, and the industry as a whole gets better. If it's too labyrinthian and nuanced and so like bespoke that no one else can really avail themselves of it, it might not be the best model. It might not be as simple or homogeneous as you believe it to be. So I think if you meet those 4 elements, you're going to be really well off. Here's my contact information. The only thing I would do a plug for is our blog, healthcarelawtoday.com. We have 150 telemedicine articles. It has all the detailed breakdown. It's all free. It's there to be a reference library for the industry. If you have specific questions, I mean, I even use it if like a client's like, hey, what's a question in a state? I'll probably go to our blog and I'll word search to see if we wrote an article on it so I can forward it to them. So we have about 20 minutes left for questions, and Alan's going to come up on stage. Thank you again so much for having us here, and hit us with your best shot.
This is our Stump the Speaker session. QA.
Is this on? Thank you both.
Oh.
For my next trick. I really wasn't very good at baseball, actually, but came through in the clutch. Good job to both of you. Thank you both. It isn't often that I would challenge Nate Lackman about any issue having to do with the law of telemedicine, but let's think of it as just a gloss, or maybe even a glitch. I think you're right regarding Virginia's law on the definition of what is required to establish a doctor-patient relationship in a telemedicine context. I don't think the code addresses that. I don't think any regulations do. We do, however, have guidance from the Board of Medicine. I would take the position that it's not, I have taken the position that that's not law. Nevertheless, the board, through a guidance document, and I believe it's 85-12 if you're really interested, takes the view that unless there is an audio-video communication link between provider and patient, you haven't established the relationship. The second point is that I think that by definition, a SOAP note cannot be based on a questionnaire because the O of SOAP is objective. It refers to the physical examination, and by definition, a questionnaire doesn't permit that. And then the final quibble is I would take the view, I would be very happy to defend the case in which it is alleged that because I don't have a piece of paper from stroke patient X granting me consent to treat him, that there's a problem. Because in every state I know of, certainly in Virginia, there is an emergency exception to informed consent, and I think by anybody's definition, a stroke would qualify. And the understanding is that in the presence of an emergency, consent is assumed, consent is implied.
I think those are good points, right? I mean, and again, the consent one illustrates how if you were to strictly apply these telehealth informed consent rules, it's not rational or reasonable in any particular use case, right? We could talk about Virginia and the interpretation on there. I think in terms of your SOAP note, you're a physician as well as a lawyer, so you raise a valid point. There was an article that was published last week by like a third-year med student called The Worrisome Rise of DTC Telemedicine, right? Which is based on these single-purpose disease state or condition state companies, direct-to-consumer, offering almost too streamlined of an approach, right? Really focused on marketing their services, and a lot of them rely very heavily on those questionnaires, right? So I think there's a valid debate going in on it. I think a lot of these companies, though their questionnaires are based on the medical decision tree processes that they learn in law school and are in published studies. One advantage that I do like about the questionnaire process in general is that it hard codes it, so it ensures that the doctor doesn't forget to ask any particular question. Now, there's always certainly the need potentially for follow-ups or things that are off script, right? And I think we're going to see a little bit of back and forth. I am absolutely aware, so let's not be like too cavalier about it. Internet prescribing is not allowed, right, in 41 states, and there have been medical board complaints and investigations. They're pending right now in a number of states against doctors who are doing pure internet prescribing. Namely, they're not using any clinically valid extrinsic medical information, and medical boards take issue with that.
Other Q&A, other Q&A.
So I have a question for each of you. On the rural side of things, do you know any other, besides telemedicine, anything else that gets reimbursed by CMS in a rural area that doesn't get reimbursed in an urban area? And then I'll ask my question for Nate now so I can sit down and you both can answer. One of the things we wrestle with in our established patient visits is, I'll make up an example, someone has some highly complex surgery with us in Pennsylvania and goes back to some state that's not friendly to telemedicine. And that patient now does a telemedicine visit with that physician as part of the global period, so there's not a separate payment for it. And the physician now wrestles with the choice of, I could either see this patient who might have something complex and do the appropriate medical care follow-up, knowing it's violating a state guideline on telemedicine, or that physician is left abandoning the best thing for that patient and taking a risk of not following up with that patient. So just your thoughts on how you'd approach that.
Yeah, let me take the first part and then turn over the difficult part for you. To answer your question, I think everyone in this room agrees, telehealth is a tool. And once you view it as a clinical tool, it makes no sense to reimburse it only in a rural area than an urban area. So there's the easy answer, and I should be quite right there. But since I am CEO of the Rural Health Association, I have to tout the rural component of it. And I would say, no, I'm not aware of any other reimbursement. They're taking the tack as they do with like tuition reimbursement and for clinicians practicing in rural and underserved areas, or grants that are dedicated or targeted towards rural areas. How do we utilize telehealth to address the shortages of that? I do want to say very briefly, I think the only aspect of that It's something our organization has not taken a policy position on. It's probably time for us to do that. When most people think of telehealth outside of this room, they think of the Jetsons model, where you've got the primary care physician talking directly to the patient, which just isn't happening out there. We're talking, as you know, about all the other components of specialty care and all those other components. But once you get to that primary care clinician talking with the patient, that becomes a little bit problematic under certain circumstances, correct? Because if you can do telehealth primary care in a community, then you have the potential to run out the primary care in that community, and then when you have to visit the ER, you've got real problems. So I think at some point we need to address when is it appropriate for that, and I think because of that, that's part and parcel of what you're talking about. Shouldn't we be reimbursing telehealth in an urban setting as well as a rural setting on that? So those are issues that all have to be parsed out. Now, for the difficult question.
Sure. So Judd's question was essentially follow-up consults over state lines when you don't have a license in that state. 5 states have explicit exceptions to their licensure rules to allow for that particular scenario, right? So the patient travels to Judd's hospital, gets the treatment that she needs, flies home, Judd does follow-up care, right? The rest don't. So strictly speaking, as a lawyer, there is not an exception to licensure for that. Does that mean that you should just abandon the patients and say, oh, sorry, you've left Pennsylvania, there's nothing I can do? No, that's not a good idea clinically. Is it a good idea ethically? No, it's not a good idea. Is it a good idea from a billing perspective because you have billed Medicare, the payer, saying, hey, I'm going to take care of this patient for the next 90 days following surgery, and you pay me that global rate in the global surgical period? It's not a good idea to ask for payment and then not do the service. In fact, you can do a modifier to your major surgery to say, I'm not doing any follow-up. And then this other doctor is going to do the follow-up, and she's going to get paid a few $100 for that. There is like a pathway to do that. Do you think that these AMCs and hospitals are doing that on a routine basis? Raise your hand if your AMC or hospital does that, downcodes that and refers it out. No, okay? So what should you do? First, I'm unaware of any medical board licensure action, right? Taking discipline against a doctor for doing clinically appropriate follow-up care in connection with that type of scenario. It's good medicine. You have continuity of care obligations and patient abandonment, and you should put the patients first. Does it mean you should be flippant about licensure laws? No, okay? So where do you draw the line? It's really up to you and your own risk profile and compass, because you could certainly refer the patient to a locally licensed doctor for the follow-up care, or you could get licensed in those states, or just choose not to do services for patients from those states. What am I seeing? I'm seeing some of these hospitals saying, okay, we're going to do the follow-up as needed, right, for that time-limited period. Contrast that with an example that you're a psychiatrist, you've been treating a patient for years, she goes to college and says, I want you to continue to be my psychiatrist, I'm in a new state, I'm going to go to, my parents paid enough money, I got into USC, and I'm a USC grad, so please, I think I'm allowed to say that. And I want you to do my follow-up mental health services. I would strongly discourage that. That's like chronic, continuous 4 years. You got to get a license or refer it.
I think you can knock out 29 questions by number 1 and 2.
Yeah, so if you want to copy the slide, just shoot me an email, okay? Just, because these are like heat maps and they're pretty detailed, I put disclosure language, but it's once in a while, I just didn't want to make it distribution. But you can personally shoot me an email and I'll give you a copy of some of those.
Very easily, I'm going to knock out the recent Pew studies have shown only 10% discrepancy in people rural, non-rural. I can easily answer that. I actually am an advisor to the Pew Charitable Trust and have talked with them about that. And it's based on the FCC data. It's inaccurate, incorrect. I've told them I disagree with this altogether. And it's part of the problem. If you don't have access to accurate data, bad policy comes up with it. So I think there's an enormous gap on broadband access, rural, urban, and it needs to be addressed. So Nate, you want to talk the state lines?
Yeah, so when the gates, state lines open, will it be an arms race on who can provide telemedicine the cheapest and fastest? Is that the best for quality? What this reminds me of is like an anecdote that a general counsel of a company told me when it comes to legal services. He said, Nate, this is what I learned. Legal services is like fast food, or it's like getting food. You can get it fast, you can get it cheap, you can get it good, okay, quality. But you can only get 2 of the 3, right? Which is kind of an interesting anecdote or perspective. I don't know if I agree with that. But when it comes to telemedicine or medical care, right, yeah, we don't want substandard care. We don't want to have like a 2-tier system even more than we already do. But at the same time, does healthcare really need to be 18% of our country's GDP? I strongly believe it does not. Right? I think that we have a lot of administrative overhead, a lot of waste, not fraud, just waste, wasted money that doesn't go to the direct care providers, doesn't go to the patients, doesn't even go to like the shareholders of health insurance plans, right? And I think that these DTC companies in particular for telemedicine with retail price points are showing how cheaply and quickly they can deliver healthcare services. Now, are they delivering the full scope of care? Of course not, right? But are these use cases that traditional providers should take a strong look at and see how can we apply some of these principles to ourselves and figure out we can deliver services faster and cheaper and maintain the same quality. There are real lessons to be learned.
Good. What happens when the gates state lines are open? Will it be an arms race on who can provide telehealth, telemedicine, cheapest and fastest? And is that the best for quality? I think that's always a concern that we're going to have, right? It's a concern, but I think about, in particular, the context of across state lines where you're just trying to have access to providers and health systems that are based across state lines. So you have the consolidation of the healthcare industry as a whole and more health systems functioning. So I think it has to be. We talked a little bit about this ahead of time. I am not concerned about the runaway cost of telehealth. They've been saying that's going to happen for the last 30 years, and we just have not seen that. Nate, your thoughts?
Sure, and we made this point in the ATA's comment letter for the RFI yesterday. The CBO in 2000, before telehealth was live in Medicare, they said in the first 5 years of making telehealth available to Medicare patients, it's going to cost us $150 million. Okay, first 5 years. In reality, the first 15 years, from 2001 to 2015, it cost only $75 million, right? So half of what they predicted in the first 5 years is what manifested in the first 15. And similarly, states that don't have telehealth payment parity or coverage laws, one of the arguments that the health plans make is, runaway cost, utilization, it's going to go so much, it's going to cost us a bunch of money, and we'll have to push that to increase premiums on the members.
That's great. I want to close on, I know we want to keep us on time for Kathy. If you may have noticed, telehealth made national news yesterday. A private firm had looked at commercial pay insurance and saw a 53% increase from 2016 to 2017 among telehealth reimbursable services. The key thing which I would urge everyone to recognize, even that's a 53% on a tiny amount. So still going ahead, we're not talking about great increases, to your point, Nate, and I just don't see that runaway train that we often see. So, Nate, you want to close out the program?
I would just like to thank everybody for being here. Really, your participation, your energy is part of what has made telehealth such an enormous area of growth. I mean, I think my first Matrix was 4 years ago, maybe 5. And just the legal landscape, the technological landscape, then we've seen all those sessions where, telehealth ROI. How do I tell my CFO? How do I tell my bosses that this is actually worth getting into? Now the whole conversation has shifted from, telehealth is mainstream. You're seeing articles in New York Times, in the Journal, in Washington Post, the AP, all about telehealth. You're seeing commercials on TV. They just call it online doctors, right? The people who are responsible for that are the ones sitting in this room and your colleagues across the country. So really, I would like to give you a big round of applause and let's just say thank you and please keep up that kind of energy.